All right, guys, we're going to get started because the recording starts at 8 a.m. And I'm sure many people are going to be viewing this online later on. The early hour wasn't that appealing. All right, so most important thing is that there are not going to be surprise questions in the test. The idea is not to torture you with the test, it's to just make sure we've done a proper job reviewing the most basic concepts, okay? So there will be no strange questions about a history of how things developed over the years, or I don't expect you guys to estimate an Eggers test for heterogeneity, and nothing like that, okay? I just want you guys to have the core concepts to really be familiar with the most basic stuff, okay? So let's just start reviewing them. So this is complementing what we've done. And as we said all along, the lectures are important, the small groups are essential, and I'm really grateful to the preceptors, and for next year, I'm hoping to enlarge the pool and to have smaller groups. I'm hoping to have at least 14 preceptors, so that's going to be a substantial improvement, because that's when you guys actually get to talk one-on-one with somebody who knows a whole lot about evidence-based medicine. So all the materials, as you know, are available in Courseworks for you to review the prior lectures, and you got the answers for the small group sessions homeworks. So let's just go into this. We apply what we call inferential statistics, and that means we try to draw conclusions about a population from a sample. And there are certain limitations to that, and the golden rule in clinical research is that your findings will apply only to patients similar to the participants in your study. And that applies both in observational epidemiology and in randomized controlled trials. It's extremely important to verify and double-check that assumption. Whenever you read a paper, the first thing you need to do is go over the population characteristics. That's an important thing, because if the population differs from your own, the applicability will be limited. So we use sample data to actually test the hypothesis about whether treatment works or not, or whether there's an association between a risk factor and outcome, for example. And what we do is we generate a null hypothesis, which is actually the counterfactual to our hypothesis. It assumes that there is no effect, that there is no association. And the kind of weird thing that we need to get used to is that we are essentially testing that null hypothesis, and we either reject it or do not reject it. And there is one degree of separation between that and actually proving the study hypothesis. So we only go as far as rejecting the null hypothesis, and we have this threshold that's actually arbitrary but universally accepted of p-value less than 0.05 to reject the null hypothesis. So we assume that the null hypothesis is true, we collect the data, we run the analysis, and then if our data strongly goes against the null hypothesis, we reject it. If not, we fail to reject the null hypothesis. The most important thing for you guys to have in mind is that there is also a clinical aspect of everything we do. So don't just get stuck on p-values and statistical significance. You also want to wonder whether something is clinically relevant. So there can be a very tiny difference in a huge study that will give you a significant p-value, but that may not have any societal value or may have no relevance to your patient. The contrary is also true. Sometimes you can have a borderline statistical significance, but you think that this is an important issue, that the treatment may actually have a substantial effect, a substantial benefit for society, you may want to pursue it further. So it goes both ways. Just don't get stuck on p-values. That's the most important thing. When we are dealing with clinical trials and also with observational studies, there are two types of statistical errors. And the way I tell people to remember this so they won't have to memorize anything is that type 1 error has to do with human nature. You want your treatment to work. You develop your drug, you're going to make a lot of money selling it, so you want it to work. You develop a device, you're very proud of it, you're the inventor, you want it to work. You develop a surgical technique, you're the surgeon, you want the patients to do better, you want it to work. So that's type 1 error, when you have a false positive finding, when you falsely reject the null hypothesis. The type 2 error is the other one, when you fail to reject the null hypothesis when it was actually false. That means it was a false negative study. So again, type 1, which is alpha, first letter of the Greek alphabet, is the probability of a false positive finding. Type 2, beta, is the probability of a false negative finding. And we concentrate on power when we're designing the study, and also we need to concentrate on power when we are assessing the results of a negative study. So those are the 2 points in time when assessment of power and the estimate for sample size comes in, which is when you want to make sure that you can actually reject the null hypothesis when it's false. And you want to really make sure your sample size is estimated based on good assumptions. So ideally, we want power to be the maximum, but we usually settle for 80% or greater. And the factors that influence power are in there. Of course, this is number one, your sample size, because your power will increase with larger samples. That's pretty obvious. Therefore, when you're estimating your sample size before you conduct your study and when you try to recruit all the people you need to take into consideration several factors. The number one factor is how frequently the event will take place in the control group in a randomized control trial. If it's an observational study, you just want to know what the effect of interest is. Variability is important when you're measuring something that is measured with substantial precision or not, such as when your outcome is left ventricular ejection fraction, which is a number, and the method you use may give you a different number. When you're looking at things that are very easy to estimate, such as mortality or stroke as an outcome, then variability is not that great a factor anymore. And of course, your significance level, if you want to make sure that you are rejecting the null hypothesis with great certainty, you may go for a p-value less than 0.01 instead of the usual p-value of less than 0.05. So obviously, if you are going to have a more stringent cutoff point for significance, if you're going to make it harder to reject the null hypothesis, you're going to need a larger sample. Is that clear? So if you're looking for a smaller effect, if your treatment is not as efficacious as other treatments, you're going to need a larger sample. If your significance level is more stringent, you're going for a p-value that's smaller, you're going to need a larger sample. And there are other things that play a role, and we're going to discuss them in a couple of minutes. P-value. Again, the reason we run the test is to either accept or reject the null hypothesis. And the threshold is given by the p-value. The p-value, P in p-value stands for probability. It's the probability that you'll see a difference like this one or larger than it just by chance, given that the null hypothesis is true, or given that there is no difference to begin with. The wording we keep on using is this one, given that the null hypothesis is true, because it's factually accurate, but also because it appears in step 2, 3, the boards of internal medicine, all over. Somebody's obsessed with that definition, so we want you guys to be familiar with it, okay? So p-value means the probability of having a difference like this one or larger than it, just by chance, given that the null hypothesis is true. So when the p-value is less than the alpha we predefined, we reject the null hypothesis and conclude that the results are significant at that alpha level. So confidence intervals are very useful to clinicians because you go a step beyond just saying this is significant or not at a certain p-value threshold. And it provides information about the range in which the true population parameter probably lies. Now, it gets a little confusing here, and actually I can tell you many clinicians don't quite understand the actual meaning of a confidence interval when you get into the mathematics of it, but the bottom line for you guys is that it expresses confidence, okay? If you're using 95% confidence intervals, you're 95% confident that the true population parameter lies between those two limits. Okay, it's confidence, it's not probability. And it depends, obviously, on the sample size. The larger your sample, the narrower your confidence intervals will be. That's to be expected. And also, in terms of variability of the data. If your data are quite variable, you're going to have a more heterogeneous signal, and you're going to have a wider confidence interval. If the confidence interval does not include the null value of zero effect, for example, if the relative risk confidence interval does not include 1, we can then assume that there is a statistical significant result. So confounding and bias. Confounding is another factor that comes with the exposure and also affects the outcome. It's the third variable that's associated with the exposure and is independently associated with the outcome. Okay? And the typical example we have is the fact that many unhealthy habits are related to smoking. But that doesn't mean that by themselves they will increase your risk, for example, having lung cancer. And if you don't adjust for smoking in your analysis, if you don't take that into consideration, you may falsely say that there is an association between that unhealthy behavior and the probability of lung cancer when the association was actually just coming from smoking. So again, smoking in that case is a third variable that's associated with the exposure, whatever other unhealthy behavior you're looking at, and it is independently associated with the outcome, in this case, lung cancer. So if we don't identify potential confounders and don't include them in your model, you will have a situation where the probability of a spurious finding will be much greater. So the issue with bias is actually much more profound. Bias is a problem with the way you design your study, how you measure the exposure or how you measure the outcome or how you analyze the results. Introduces systematic error. Bias is systematic error. And the problem with bias is that you cannot adjust for it. Once you've got bias, you're dead in the water. There's nothing you can do about it. So that is actually extremely important when you're designing and conducting your study, because if you didn't prevent the occurrence of bias, you're going to be stuck with it. You can adjust for confounding, okay, to a degree, but you cannot control for bias. So blinding is the most important thing we do to prevent bias. And whenever feasible, we try to implement double blinding in RCTs, and we also try to implement blinding when you're assessing an exposure to see whether that's a risk factor for the outcome. And also we use blinding when you're assessing a diagnostic test and you want to be sure whether it measures up to a gold standard. In other words, whether it's actually being accurate or not. In all types of studies, we try to implement blinding as much as possible. In randomized controlled trials, sometimes it's not ethically feasible. Okay? Sometimes you cannot hide the fact that you're putting in a pacemaker or a defibrillator or you're performing a major surgery. There are some sham surgeries being performed for tiny operations, but that's a very tricky ethical item, and it has to be taken into consideration with much care. So the most important thing is that investigators need to be blinded. They need to be blinded when they're determining the exposure. So when you're looking at the, for example, the predictive value of a certain protein in the serum to predict who's going to have Alzheimer's disease, obviously the person measuring the serum level of the protein need to be blinded to the clinical status, because if he or she knows that the patient has full-blown Alzheimer's already and that person gets a low protein level for that participant, the investigator may be prone to repeat the measurement until they get a result they actually like. So that person ascertaining the exposure should be completely blinded to the clinical status of the patient. And the same thing goes for randomized controlled trials. We blind investigators in terms of who is getting assigned to what treatment, and we call that allocation concealment. This is another definition that's very fashionable. You're going to see it all over. There will be questions in your step 2 and 3 exams. Allocation concealment only means that the randomization procedure was blinded, that nobody was intervening, that was completely automated, performed by a computer, and there was no human intervention. And the other side of things is that by the time you're ready to ascertain whether the outcome is present or not, it could be the outcome in your clinical trial, or it could be the outcome in the observational study. The people determining whether each participant in the study had the outcome or not should be blinded to the exposure. And that makes a whole lot of sense. You don't want people determining whether somebody had an outcome, knowing what drug the patient was assigned to in terms of the RCT. So again, this is just a graphic for confounding. Confounder is the third variable that's associated with the exposure and is independently associated with the outcome. If you don't put it in there, you will have some error. You will have confounding in terms of assessing the association between exposure and outcome. So there's a difference between that and effect modification or interaction. Effect modification is the situation in which a third characteristic changes the relationship between exposure and outcome without being associated independently with either of them. So when a treatment, for example, in RCT, is shown to work differently depending on who you are in terms of race, gender, etc., we call that an interaction. And effect modification is not biased, but it's useful information. So sometimes what we do is, at the end of the clinical trial, once you've gotten a relative risk estimate of, say, 0.8, which is a 20% relative risk reduction, then you go further and start looking at relative risks within strata of gender, age, smoking status, diabetes, hypertension, coronary artery disease, and so forth and so on, because we want to know whether the treatment works similarly in all those subgroups. And we are essentially looking for an interaction. The two expressions mean the same thing. So the typical example of that in observational epidemiology, which also applies to our clinical work, is the fact that contraceptives, unless you have a prothrombotic genetic condition, will give you a tiny increase in risk of having a deep venous thrombosis. However, if you smoke, your risk of having a DVT is astronomically higher. Still low at a population level, but much higher for each individual person. The relative risk is much higher. So if there is effect modification, the solution is to do a stratified analysis. You have to analyze your data depending on whether the young women smoked or did not smoke. So moving on quickly, it's extremely important for you guys to remember the difference between incidence and prevalence. Incident cases are those that are newly diagnosed over a given time period. It can be a month, it can be a year, it can be any predefined time period, but it's the new cases that are just being diagnosed, people who are being diagnosed with that condition. Prevalent cases is the sum of people who have the condition at that point in time. Okay, they developed the disease earlier, or they just did it, whatever the case might be, they have the condition at a given point in time. It can also be prevalence over 6 months. You can actually count the number of people who have the condition in a given population over 6 months, and that will include all the incident cases over those 6 months. And I don't know if you remember, I mentioned the other day that you can have a situation in which you have a disease with a whole lot of incidence, but it either has a very short course and it's self-resolving, or it's fatal very quickly, and therefore the prevalence will be low. Okay? Or you can have something that appears slowly over time, but it's not quickly fatal, and people carry it for decades, and therefore the prevalence is high. And the example of that is diabetes. So biases in cohort studies. Selection bias is obviously extremely important, how you select the people who are going to be in your study. And again, it goes to the golden rule of your findings being applicable only to patients just like the participants in the study. If you over-select, you won't have much in terms of applicability of your findings to the general population. It's extremely important to know whether there is attrition or not, whether you're losing too many people to the follow-up. And the most important thing to remember here is that you really want to know whether people are being lost to follow-up differentially depending on who they are. For example, the obvious case that you need to worry about is in an RCT, when people in the intervention arm are being lost to follow-up much more frequently than the control arm, because that could mean that you're doing something horrible to them, and that's why you're not seeing them again. Okay? And it's also important to remember that if you're assessing an outcome that's not including all-cause mortality, if you just ignore people who are lost to follow-up, it could be that they are dead and you just don't know about it, and you overestimate the outcome for something else when you run the analysis for people who are available to follow up. So just keep in mind that whenever you look at study, you want to make sure that the follow-up was decent in both arms of the study. So it's very important to think about whether there is bias in terms of observational studies, particularly cohort studies, because there's no way to fix that in statistics. So this is a very common type of bias that people still fall for, and it's prescription bias, also known as confounding by indication. It means that when you're looking at the effect of a drug on a given outcome, you can falsely get the impression that there is an association between the use of that drug or the prescription of that drug and the outcome, just because people who are higher risk for the outcome are getting the drug as treatment. And the obvious example is when we have patients with advanced chronic kidney disease, the first thing we tell them is, do not take any NSAIDs. Do not take Motrin, do not take ibuprofen. Actually, I have a printout of 1,000 different names, including names in Spanish for products from the Dominican Republic that I give to my patients and say, don't take any of these. And we tell them, take acetaminophen, take Tylenol, here's prescription. I'm giving you 100 tablets, and I make sure that you have a bottle like that every time you come back to see me. So if a genius decides to look at the association between acetaminophen and progression of kidney disease in my patients, that person will say, wow, acetaminophen predicts who will have chronic kidney disease and then end-stage renal disease, okay? And I cannot tell you how frequently I've seen in the recent past papers coming for review that are actually still falling in the trap of confounding by indication, okay? Because it can be more subtle than the example I just gave you. Case control studies. When a disease is rare or takes a very long time to develop, it's not cost effective to do a cohort study. So there are certain types of cancers that develop, thank God, relatively rarely in a population, and we just want to know whether there is a case for that, a significant cost for that. In some cases, what you want to do is a case control study. So what's important to remember about case control design is that the recruitment starts with people with the condition, with the disease. So you first recruit people with the condition, those are your cases, and then you recruit people without the condition, those are your controls, and then you go back in time and look at the exposures, and you see whether a certain exposure is associated with your risk of having the outcome or not, but you're going backwards in time. The most important thing to remember is you start recruitment with people who already have the outcome, those are your cases, and you match them against people who don't have it. And then you take a look at exposures in the past. Sometimes a case control recruitment will take place within a cohort, like the Framingham cohort, and that can be confusing. And actually, I've seen that question in step 3 a whole lot. I'm not sure about step 2, but it's a very common question. They tell you within the Framingham cohort, we pick people with Z condition, which is very rare, and we match them against participants who had the same age and gender, and then we looked at a given condition, a given exposure to see if it was associated or not. Cases, again, are people with the disease, controls are people without it, and what you do is you match them. What's important to remember, though, and sometimes people forget this, is that matching can be performed for everything except for the exposure of interest. Because if you match them by exposure of interest, obviously you won't see any type of association. Okay? You try to make them as similar to each other as possible, except for the exposure you're assessing. So collection of data can be made from medical records. You can do questionnaires. You can interview people. But the most important thing is that you're going back in time. So there is no temporal relationship clearly in there. You're assuming there is because you're going back, but you didn't collect the information about the exposure first and then documented the outcome. So we cannot estimate the risk. And the other thing is you don't have any idea as to what the prevalence is. In other words, the fact that you're artificially matching your cases and your controls means that that match will create an artificial mix of cases and controls. It won't reflect the prevalence in the population. So that's the reason, those two reasons actually make us estimate the odds instead of the probability of developing the disease. You're going backwards, and therefore you're doing an odds ratio instead of doing a relative risk. So now you want to know what the odds are of developing the disease or not developing it. So this is what you need to remember about the odds ratio. You're just doing what we call a cross-product calculation. You look at the usual 2x2 table, and you have the usual cases and control, exposed and unexposed, and what you do is you do a cross product. You multiply the cases, the number of cases who were exposed times the number of controls who were unexposed. That would be the true positives and the true negatives, and you divide that over the product of the people who are cases but were not exposed, okay, times the number of controls who were exposed. So just forget about all the mathematics involved in getting to this point, completely unnecessary to you as clinicians. If you just remember that the odds ratio is not dealing with probabilities but with odds, because you're going backwards, and you don't have a good reflection of prevalence in this 2x2 table, and that's the reason we are doing this as an estimate of relative risk. That's all you need to know. And the way you do it is, again, you do a cross-product ratio. You multiply the true positives times the two negatives and divide that over all the falses. Okay? If you remember it that way, you'll never have to memorize the 2x2 table for the odds ratio anymore. So the interpretation is the same as for the relative risk. If it's greater than 1, there's greater risk of the disease given the exposure. If it's lower than 1, you're lowering the risk given the exposure. And obviously, when you have confidence intervals, if they include 1, that means you're not certain. That means your p-value is not going to be less than 0.05, and you won't have a statistically significant association. So in terms of diagnosis and screening, this is extremely important. So again, 2x2 table. By convention, we put disease status up here and test result over here. And the one thing to remember is that when you're dealing with the 2x2 table, this, everybody with the disease, over the total sample, that's your prevalence. So this is important. Your pre-test probability assessment, your assessment in terms of the history and physical as to whether the patient may have or not the condition based on presentation before you do the diagnostic test, actually goes in here, okay? You're saying the pretest probability of my patient is 60%. Well, you're saying people just like my patient, 60% of them will have the condition. That's where the pretest probability information goes. It goes into the prevalence. And essentially what you need to remember is that when you're assessing the test for the first time, when you have access to the gold standard, when you have performed a diagnostic confirmatory procedure in your participants, you're going to be telling the world what the sensitivity and specificity of the test happen to be. This is what investigators do when they're validating a diagnostic test. It's not what you guys will be doing when you use the test in your clinical practice. You'll be using reported sensitivity and specificity to assess the predictive value, to assess posterior probability given a test result. So this is just a reminder of how you estimate sensitivity and specificity. Your sensitivity is the probability of having a true positive finding in everybody with the condition, whereas the specificity is the probability of having a negative finding in everybody without the disease. So one is true positives over all people with the disease, which is true positives and false negatives. The other one is true negatives over true negatives plus false positives. Now, the predictive values, which is what you're going to be estimating, can be negative or positive, or sometimes it can be 1 minus 1 or the other, and I'll get into that in a sec. So if somebody has an abnormal test and you want to estimate the probability that they do have the condition, you're estimating the positive predictive value. And in this case, notice the denominator. It's all the positives. You don't have false negatives in there anymore. Oftentimes people are confused in terms of the difference between sensitivity and specificity, sensitivity and positive predictive value. Well, the difference is when you're in your clinical situation, you're trying to estimate the probability that somebody has the condition. You don't know whether they've got it or not. So you don't know who the group of people with the disease are. You're trying to identify them. So obviously the denominator is going to be given by the test result. If your patient happened to have a positive test result, this will be your denominator. And your numerator will be determined by the question. In this case, your question is, what's the probability of my patient having the condition? This is the most common use of a positive test, of course. So when somebody has a negative test, you want to know the probability that that person does not have the condition. And now the denominator is everybody with a negative test. And your numerator will be people who are true negatives. And you get there by always remembering which type of test result the patient had, and then determining the question you're asking. So in this case, you're determining the probability of the person not having the disease. Okay? If you want to know the probability of somebody having the disease given a negative test, you have to do 1 minus that. Or in other words, false negatives over false negatives plus true negatives. So the likelihood ratio is the ratio between two probabilities. And in case of the likelihood ratio of a positive or abnormal test, it's the probability that you have this degree of abnormality given that you have the condition over the probability of the same degree of abnormality given that you don't. And you can just forget about what I just said. If you remember that the likelihood ratio of a positive test is sensitivity over 1 minus specificity, that will be good enough. But in case you're interested as to where that came from, it's the statement I just made. The other thing to remember is that we actually estimate the likelihood ratio for a completely normal or negative test in a different way. We do 1 minus sensitivity over the specificity. Okay? Oftentimes, people just remember this one, and when they're estimating the value of a diagnostic test in somebody who had a normal test, they forget to apply this one. This is the right one to apply if the person had a completely normal test result. It's the likelihood ratio for a negative test. Okay? This is Fagan's nomogram, still appears in many iterations of every single test. It was created in the 1970s, and essentially just puts pretest probability estimates over here. And as you can see, it's in decimal points. So this will be 90%. And here's the likelihood ratio. So in this case, somebody had a pretest probability of how much? Right, that's 10%, right? And this likelihood ratio is a very positive one. It means the patient had a very abnormal test result. And what is the post-test probability? What is the probability of the person having that condition after that test? Huge jump because you have a highly informative test. Okay? So the positive likelihood ratio is very big. What is important to remember is that you are actually going to have many likelihood ratios when your test result is in numbers. In other words, you're dealing with a continuous variable. The cutoff point for abnormality will matter quite a bit. So when you measure, for example, troponin to determine whether somebody has a myocardial infarction or not, if you say, I want to know what the sensitivity and specificity is for my troponin measurement, you will have to define the cutoff point, the value that you'll consider abnormal. And in actuality, you can also have several different cutoff points, and obviously you're going to have a different likelihood ratio for each one of those cutoff points. So what matters is for you as clinicians to remember that if you have a really bad condition that requires immediate treatment, such as pulmonary embolism or severe CHF, when a patient may go into pulmonary edema, you really want to have a situation in which you minimize the number of false negatives because you want to start treatment right away. And you'll rather start treatment unnecessarily in somebody who doesn't need it and then stop it right after you exclude the condition than to wait for too long and your patient die in your hands. So in the setting of emergency room care, for example, when we look at somebody who may have pulmonary embolism or CHF, the diagnostic test has a very low value as a diagnostic threshold because we want to minimize the number of false negatives. What you achieve by doing that is you maximize the sensitivity and the negative predictive value of the test. And obviously, you're going to lose in terms of specificity and positive predictive value. Okay? Once again, when you want to minimize false negatives, you improve the sensitivity of the test and the negative predictive value. So it's also important to remember the value of pretest probability, and this cannot be overemphasized. A very common problem with people who are in internship is that they overvalue diagnostic tests. And if they have a negative test for something, say, oh, forget it, this person doesn't have this condition. And they completely forget the pretest probability, the prior probability estimate. So when you start off with somebody having an extremely low pretest probability, the famous case of the student who's having completely atypical chest pain before finals and has no cardiovascular risk whatsoever and presents to the ED, and some genius decides to say, oh, this may be acute coronary syndrome and I need to get an EKG and troponin measurements. Well, no. When you already start with an extremely low pretest probability, there will be no benefit. You will, even if you have a highly accurate test and it comes back abnormal, you won't know what to do with that because you will still remain within the low probability territory, and you're probably just going to waste time in more diagnostic tests, and you're going to put your patient through an entire diagnostic procedure that will just give him or her anxiety unnecessarily. So the other extreme situation is also possible. When you already made the diagnosis, when the presentation is so typical that you made the diagnosis, you don't need a confirmatory test to start the treatment. If somebody comes to you with a tattoo on her forehead saying, I've got pulmonary embolism because the presentation is so typical and the risk factors are all there, you should just start sub-Q enoxaparin right away instead of waiting for somebody to run some confirmatory test and waste the patient's time that way. Okay? By the same token, if you do perform a diagnostic test in that person, it comes back negative, his or her probability of having the condition will not be extremely low. It will continue to be in the higher range because you started off with a very high pretest probability. So the bottom line is, and this is a very common step 2 and step 3 question, is people who benefit the most from a test are people with intermediate probability, because in them you see the highest jump towards higher post-test probability or lowest post-test probability with a positive or negative test respectively. So finally, when you move from diagnosis to screening, screening is when you're running a test to look for a disease when the patient is still asymptomatic. That's the one difference between diagnosis and screening. Diagnostic procedures are performed in people who are symptomatic, and you want to ascertain the cause of their symptoms. Screening is you're looking for something that's important because you can introduce a treatment, but the patient is still asymptomatic. So what are the features that make it desirable? First of all, you need to have an accurate test. Otherwise, it's going to be a complete waste of time. And the disease has to be relatively prevalent. Okay? It can be so rare that it's inconsequential. But sometimes it will be relatively rare, but it's so dramatic in its consequences and it's so eminently treatable that you really want to screen for it. And the example for that is phenylketonuria. Okay, it's not that prevalent, but it's so dramatic, and we have things we can do about it, so we screen for it. And obviously, you're going to care the most about conditions that will give you substantial morbidity and mortality. If it's a trivial condition, well, you may not care as a society. And finally, you want to have an efficacious treatment. Screening for things that have no treatment actually has no societal value. And that's a huge problem right now because many people are going, for example, for genetic testing for Alzheimer's disease, and we don't have an effective treatment for that. It may be important in terms of you getting life insurance or planning your affairs. The problem is at this point in time, people are not protected against insurance companies searching for your genetic testing. Believe it or not, it's not illegal for an insurance company to do a background check on you and see whether you ever underwent genetic testing or not. It should be illegal, but it's not. So anyway, if there's no efficacious treatment, you probably shouldn't be screening for it. RCTs. Just remember, there's a golden rule about internal versus external validity. When you clean up your experiment, when you take people out because they may have a different type of pathophysiology, they may respond differently to the treatment, and you want to clean up your experiment, you're increasing your internal validity, and there's nothing wrong with that. However, you're going to lose applicability. You're going to lose the ability to generalize your findings to everybody, and therefore your external validity will go down. So you just need to balance out what you want, and you need to take a careful approach. You need to think about it. The most important thing in an RCT is to stay away from bias, and we start with the randomization.
We randomly assign people to one treatment arm or the other. We don't want investigators to select who gets what. We don't want participants to self-select, so we do it randomly. And in order to really make sure that it's properly performed, as I said before, it has to be completely blinded and automated, and we call that allocation concealment. So in order to keep bias away, the things we do in an RCT after we randomize is we double blind whenever possible. Sometimes it's not ethical, it's not feasible to double blind, but we try as much as we can. And when we cannot blind the intervention, at least we try to blind the ascertainment of the outcome. And finally, we apply the principle of intention to treat at the time of analysis. Intention to treat just means analyze as randomized. You randomize somebody into a group, that's where you analyze them at the end of the study. You don't move them around. Intention to treat is a basic principle that we have to apply at the time of analysis to stay away from bias. So randomization not only keeps you away from bias, but also reduces the possibility of confounding. And you can be absolutely sure that it has worked when you have a mega trial. When you have a huge number of participants, there will be a completely balanced distribution of baseline characteristics. When you have a smaller studies, then you can have a little bit of confounding. What do? Well, you think about what is important in terms of a potentially strong confounder, and you stratify your randomization procedure. In other words, if you know that ejection fraction is associated with cardiovascular death, when you're randomizing people to look at the effect of a treatment on death over time, you may want to stratify them by ejection fraction, okay? So stratified randomization will completely keep you away from confounding by that specific characteristic. So this is essentially an example of that I gave you during the lecture. When you have myocardial ischemia, you can have higher mortality. So when you randomize people to your intervention, you may want to stratify by ischemia to avoid that confounding. So essentially, you eliminate the possibility of this association in a smaller study. Again, if you have a huge study, if you have a very large budget and you can recruit as many patients as you want, there's no concern and there's no need for stratification, except for one thing. You may want to stratify by treatment centers if it's a multi-center study, because you may have a relatively small number of people at each center, and you don't want the outstanding center to get all the intervention participants in it, and you don't want another center with a lower standard of care getting all its participants randomized to control. That can really bias your estimates. So, interpreting subgroup analysis. Sometimes this is a little confusing to people. The most important thing is when you look at a figure, well, we're going to get there. When you look at a figure, is to remember that you're doing this after you already looked at the primary comparison, okay? You had your primary hypothesis, you run your statistical test for that, you say, yes, my p-value is less than 0.05, I reject the null, I'm satisfied that my treatment works, and then you move on to see whether it works for everybody else or not. But when you have a situation in which your primary analysis was negative, when you couldn't reject the null hypothesis, it's much trickier to go into subgroup analysis because that can just be a fishing expedition. So just keep that in mind whenever you're looking at the results for subgroup analysis, okay? You're going to look at it from a different perspective depending on whether the primary outcome was already proven or not in terms of efficacy. So you're going to get point estimates, which is the value of the statistic for each subgroup, relative risk, hazard ratio, whatever that may be, and then you're going to have a confidence interval around that. So the first thing you do is you look at the overall study result, and usually you're going to have a frame of reference by a line in there, and you can follow that up and down and look at the point estimates for everybody else. Don't start by looking at the confidence intervals, okay? Forget about them for a second and just look at the point estimates, because the point estimates will be more reliable. When you start breaking down your sample into subgroups, you're losing power. The confidence intervals will get wider, and many of the subgroups will cross one. That doesn't mean it doesn't work for them, okay? That's a very common confusion. Don't fall into that. If the point estimates are all on the right side, if the treatment works for the entire patient population, you had a significant finding for the overall study, then you expect to have point estimates aligned around that same vertical line. It should work for everybody else. So look for consistency with the primary comparison. And number two is, if you do see a divergence, if there is a point estimate that seems to suggest a completely different treatment effect, well, you need to think about why. And sometimes you are going to be able to come up with biologically plausible explanation for it, and sometimes you will be completely flabbergasted, and that could be just a very bad statistical fluke, or it could be something that we never considered before, and something that's worth examining and going back to basic research and looking into mechanisms. So we will not be surprised to see an interaction if you already expected somebody to have more or less benefit, and when we know that the pathophys is slightly different in that group. Okay, biological plausibility always plays a big role in how you interpret the studies. So how you look at the confidence intervals and the point estimates to determine whether there is an interaction by those two subgroups or not. The most important thing is that if you have complete overlap, if the confidence interval of one includes the point estimate for the other, I'm going to show you an example of that, you can be sure that there is no interaction and the p-value should be greater than 0.05. Okay? If there is complete overlap, there is no information suggesting that the treatment works differently depending on who you are in terms of those two subgroups. If there is a tiny overlap, if there's a tiny bit of overlap of the confidence intervals, sometimes the p-value can be slightly less than 0.05 because confidence intervals are estimated in a very conservative manner. So that is a possibility. And if they're completely separated from each other, then you can be sure that the treatment effect is really different and there is good evidence of interaction. This is the first example. In here, you can see this point estimate is included in this confidence interval, and this point estimate is included in here. So left ventricular ejection fraction here had no effect modification. There was no interaction. You can be certain that the p-value for this interaction estimate should be greater than 0.05. Is this clear? Complete overlap. Very good. So in here, you have the opposite situation. You have one distribution over here, another one over here. There's no overlap whatsoever. You can be pretty certain that the p-value for this interaction should be less than 0.05. In other words, in this case, there is much greater effect or much greater reduction in risk, okay, as compared to the other subgroup. And when you have a tiny overlap, I don't think I have an example of that, you may have a p-value that's mildly significant. So again, the guidelines to interpret multiple comparisons in RCTs, if you're looking at subgroups and that's your multiple comparison, you're comparing one group to the other over and over again, what matters is whether the study, the overall finding was positive or not. If you have a positive finding, then it's likely that it will work for everybody. So from a Bayesian perspective, your pretest probability going in is very high. You don't need to do adjustment for multiple comparisons in that situation. However, if somebody comes to you with a negative study, they fail to reject the null for the main comparison, and then they give you a table and they say, oh, but people who are taller and people whose BMI is lower than 23 do benefit from my intervention, and therefore they should get the drug prescribed to them, you're going to say, wait a minute. That can be a fishing expedition. I really want to know how many comparisons you performed, and I want to adjust for multiple comparisons. And the comparison, the adjustment that everybody knows is Bonferroni, the Bonferroni equation. It doesn't matter at this point in time, but you're going to ask for some sort of adjustment, okay? And always, biological plausibility must play a role, okay? You really need to understand why that is taking place, and it needs to be based on prior observations, not something they hypothesized after the fact. So this is a very common type of question. If you're planning a study to assess the efficacy of a new type of treatment, and mortality with the older treatment is around 15% at 3 years, your statistician estimated you'll need 725 participants to have 90% power to reduce the death rate to 8%, from 15% to 8%, at an alpha level of less than 0.05, assuming that 10% of the participants will lose to follow-up. So you will need a larger sample. Can you guys give me an answer? Just yell it out. Yeah? C? Anybody else? So here you're reducing the number of people lost to follow-up from 10% to 5%. Is that going to go against your power? No. Right. So here, mortality rate with a new ACD will be 5%. You're going from 8% to 5%. There's more efficacy. You're reducing mortality even more. Do you need a larger sample to prove that point? No. If you want to have 85%, and here you had 90%, you're satisfied with less power, are you going to need a larger sample? No. So absolutely, the answer is C. So estimating the sample size, once again, you need to know your condition you're treating. You need to estimate the event rate in the control group. If you fail at doing that properly, you're not going to have good power if the event rate happens to be lower than estimated. And this is a very common problem. People are essentially overestimating risk all the time. And, you know, unfortunately, what's good for the participants when they don't have events, that's bad for your statistical power. Then you really need to understand your treatment, how much you're going to reduce the event rate by introducing the treatment, how many people will be lost to follow-up, how many people are expected to cross over. That's a very common problem when you have a dramatic intervention, a whole lot of benefit, and the treatment is already available by other means. And that was the case with all the clinical trials with defibrillators. People were able to get defibrillators in the control arm by going to a private cardiologist and paying for it. And this is intervention fidelity, just means that you were able to carry out the intervention as planned. If you have a behavioral intervention, you were able to counsel the patient as frequently as you expected to. If you have to give one injection a week, whether you were able to actually bring people back to the office to inject them once a week, that's intervention fidelity. And obviously you guys already know by now what the power and the type 1 error should be. So the sample size estimate are based on these assumptions. These are the things that you discuss with your statistician when you're coming up with your sample size. And therefore, these are the things you need to check out at the end of study to see whether study is a falsely negative study or not. So you end up with a study that does not reject the null hypothesis. You want to know whether that's a false negative study or not. So you have to go back to the drawing board. You have to go back to the assumptions they made, and they will be reported in the paper, so it's easy to do. And you want to know whether they actually recruit the number of people they planned to, whether they had the actual event rate in the control group they expected to have, and whether the losses to follow-up and crossovers were rare enough for you not to have a loss in power. And finally, whether the intervention was carried out as planned. If you say, yes, I did recruit everybody, I did have the event rate I expected to have, I didn't have too many people lost to follow-up, crossovers were rare, and the intervention was implemented as planned, and you still have a negative study, well, the only remaining explanation is the treatment didn't work. Okay? So these are the points, this is the checklist you want to make sure you go through when you have a negative study. So if you answer yes to all the questions, then it's probably a truly negative study. But whenever there is a deviation from an assumption, first you need to assess how strong that violation of the assumption was. So if it was a tiny deviation from the assumption, it won't have a major role in giving you a false negative study. And also, you want to see whether there is any trend, any non-significant trend. So if you don't have major violations in terms of the assumptions for power, and there is no trend, if your relative risk is 0.95, 0.98, then it's quite likely to be a true negative finding. So survival statistics, the relative risk is the one we want you guys to do. You just do event rate in the treatment arm over event rate in the control arm, and the event rates are just the number of events in each arm over the number of people randomized to that group. It's very useful. It's got limitations because it doesn't adjust for differences in follow-up length and completion. So if you have losses to follow-up and they're different depending on what arm the patients are in, that can bias your estimate of relative risk. And of course, it's not taking into consideration confounding at all. The number needed to treat is calculated inverting the absolute risk reduction. So the absolute risk reduction is just the event rate in the control arm minus the event rate in the treatment arm. In other words, in absolute terms, you're evaluating how much you reduce the event rate by introducing the treatment, and then you take that and do 1 over the absolute risk reduction and get the number needed to treat. So the number needed to treat is the number of people you need to expose to the new treatment to prevent one bad outcome. So the relative risk reduction is 1 minus the relative risk, and this is the one we usually share with the patients because they can easily grasp the concept of something being 20 or 30% off. The number need to treat or number need to harm is the one statistic we use frequently to discuss the public health implications of our findings. So a crude relative risk can have some biases, and that's why we need things that actually apply censoring. And those things are Kaplan-Meier curves and the hazard ratio. What you need to remember is that whenever you look at the significance of any of these statistics, Kaplan-Meier curves, the log rank, or the hazards ratio, you're looking at survival rates from day one. You don't just look at the end. You're comparing survival throughout the entire follow-up of the study, from day 0 to the very end. You don't just go to the final day and then compare the number of people with events to no events. That's a relative risk, okay? So that's an important thing. Here's a Kaplan-Meier curve. You have a depiction of the cumulative probability of survival, or it can be the cumulative event rate if it goes up like this. And in this case, you have a hazard ratio that's not statistically significant because the upper confidence limit includes 1, and the p-value for the log-rank test confirms that, so you don't have a good finding. So the number at risk below the x-axis represents the number of people who gave you that length of follow-up, who provided information for that period of time. And it's important to remember that the numbers fall just because these people enrolled very early on and they are available for follow-up throughout the entire study. It's not because everybody else died, okay? It's just because there's a huge overlap between recruitment and follow-up, and these patients obviously did not have the outcome and were still available for follow-up, but they got enrolled very early on, okay? It's not that everybody else is dead. And we used those numbers just to have some sort of confidence estimate in terms of how much we can rely upon those points in the curve. And we are just be worrying if there is sudden divergence when you have very small numbers at risk. Finally, meta-analysis. This is the checklist for meta-analysis. Publication bias is very important. We really want to make sure that all the negative studies were in there, specifically if they are small. There's a tendency not to publish smaller negative studies, and the way we assess visually whether it's publication or not is the funnel plot. You really need to be familiar with this concept. In the funnel plot, we put in the vertical axis some estimate of the precision, which is also related to the sample size. So larger studies with more precision will be up here. And then you have this distribution that shows greater divergence in terms of a whole lot of random noise at the bottom with smaller studies. If you have publication bias, you'll have a truncated funnel plot. There will be no tail on the size of no benefit or harm, and that's the one pattern you need to visually identify, okay? It's a truncated funnel plot and suggests the presence of publication bias. There are limitations in terms of how we visually estimate that, so we use Egger's plot, and if there is no publication bias, the intercept, the Egger's plot will be at 0. If there is publication bias, it will differ from 0. So non-inferiority, the one thing I want you guys to remember is that we need non-inferiority trials because we cannot ethically perform placebo-controlled studies if there is already an efficacious treatment. And that how much harm we accept as part of non-inferiority is the most important ethical item. Okay, you expect to have some benefit in terms of cost, convenience, acceptability, but you cannot accept too much harm because that's not ethical for either the participants in the study or your patients in the future. Thank you. Thank you. Sorry it took so long. I think we made it more fun. This one too. Good luck on Tuesday.
Thank you.
Oops. I'm still wearing. I'm gonna take it home.
Yeah.
Sure, absolutely.
The difference between predictive value and likelihood ratio, is it that likelihood ratio is interpreting a test and as it is judging a test and a predictive value?
The predictive value is what you get a yes. So you incorporate the predictive probability with the likelihood ratio and you get a post-test probability. So the predictive value, if it's positive, the p-value for example, that's the post-test probability for a random. So in that famous nomogram, you have predictive probability here, likelihood ratio in the middle, and post-test probability. So if you have an abnormal test, the post-test probability is the positive predictive value. Well, the positive predictive value is